Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a Haemareg.
And let's get started on today's topic.
From basics
to brilliance. Okay, hi David, how are you?
I'm good, thank you. Ready for some more hemostasis fun?
Excellent. Today I think we've got a very interesting topic of inhibitors in hemostasis.
It's often said that they are the most interesting part of hemostasis.
I mean, what do you understand by the word inhibitor, just to start?
So when I hear inhibitors, my head automatically goes to a lupus antibody, anticoagulant, sorry, and then antibodies. So some kind of thing that the body's made or sort of got from somewhere else. So those are, but probably benefit from your slightly more eloquent description of them.
I don't know about that. But yeah, you're right. In general, it's useful to just remember that inhibitors are antibodies. Like all inhibitors in hemostasis are an antibody of one form or another. And generally you can divide them into either things that are targeted against specific clotting factors. So antibodies against Factor VIII and Factor IX will be the most commonly occurring ones. But then also you can have antibodies to phospholipids, as you said, which is your lupus anticoagulant, which just to say in this podcast today, we are not going to talk anything more about lupus anticoagulants because that will come up in antiphospholipid syndrome, which is planned for a bit later on in this coagulation series. So we're just going to talk about antibodies against specific clotting factors today. Yeah.
Great. Thank you.
Okay. So when might you think of somebody having an inhibitor? Like what might make you suspect an inhibitor?
So because I've listened to this podcast before, I haven't willy-nilly done a clotting screen. I've got a significant history first.
Okay.
And I've heard some strange sort of bleeding histories, whether that's to do with like menorrhagia or whether they've had some, excessive bleeding problems that I can't really account for. Then I've done a clotting screen and I've probably got a prolonged APTT. That's probably where I start going, And I've also, because I've listened to this podcast, I've ruled out any preclinical analytical problems, like I've accidentally given them a DOAC or used a heparinized syringe.
Yeah,
so that's when I would start going, what's going on here?
Yeah, great. So exactly, times in which you're going to suspect an inhibitor are either going to be based on the clinical history. So in particular, that's patients that don't respond to treatment, like patients with Haemophilia A or B that don't respond to treatment in the way that you suspect they would, or you would expect them to, as well as also like breakthrough bleeding, which isn't accounted for by, non-compliance or increased trauma or change in activity. So a clinical history is one. So unusual bleeding or a lack of response to treatment. And then the other thing, as you said, is finding a prolonged clotting test, usually the APTT, that then fails to correct on a mixing study, as you said, because your mixing study is your screening test for an inhibitor. The most frequent inhibitor, which is what you did correctly identify at the beginning of our chat today, is the lupus anticoagulant. So that's the most common one. But it doesn't mean that the Factor VIII and Factor IX inhibitors aren't still around and aren't still relevant and something that we definitely need to understand. I'll try and bring this to life with a couple of cases that maybe we can circle back to at the end and see whether we can shed more light on the cases once we've discussed this topic a bit more. So I'll start with a case of a patient with Haemophilia B, and he's had his third dose of BeneFix, which is a replacement Factor IX, and he then develops anaphylaxis. And my question to you is, what do you think might have happened here? And what would you want to do?
Yeah, so I guess anaphylaxis is quite quick, isn't it? You
Hmm.
know, it's not sort of a delayed thing. So it sounds like they've been having. I take it that its benefits are recombinant.
Yes.
So they have produced an antibody to this, and then over time, and then when they were given it this time, they've had an anaphylactoid kind of response to it. Is that kind of on the right page?
Yeah, that's correct. So, in particular with this patient, they've, as you say, formed an antibody probably on the first or second exposure to BeneFix, and then by the third exposure, because when you have an antibody, you get your initial production of antibody, which is a slow rise, and then once you've got your memory cells, you then get this antibody response, which is much quicker. And that can then cause a much higher and faster peak of antibody concentration, which in this case has mediated an allergic reaction. Yeah. And we'll come back to that at the end. Another case is a patient with severe haemophilia A, so a factor VIII level of less than 1, and they've come in with a joint bleed in their ankle, and they've given themselves their usual emergency dose of factor VIII replacement, and the joint is no better, and they all have. When we talk about haemophilia A, we'll talk about the fact that they have an emergency plan in place and they know what and how to give their emergency dose of factor VIII, and then at what point to then seek further medical advice. And they're usually pretty expert at this, and they can pick up their joint bleeds pretty early on, usually with like a tingling sensation or something. But this patient's come in with a really swollen and painful ankle, which they feel is getting worse despite treatment. So again, that's something that we're going to sort of discuss now, talking about inhibitors as to what investigations you would do next, and I guess we could talk a bit about how you would manage that. Okay, so those are two cases. So we've said what would make you suspect an inhibitor, so either something on the clinical history or the clotting test. And there are also times that you need to screen for an inhibitor in patients with haemophilia A and B, before and after big operations, for example. But what would be your initial screening test if you thought somebody might have an inhibitor?
So we've done our mixing study.
Okay.
I'm trying to remember back to when we did the mixing study at different titers, didn't we? And then you could get a bar that came across. I'm completely murdering this. And then when it sort of didn't come out parallel, it was because there was some kind of deviation and you're going to have to help me here.
No,
I'm
that's
blundering
fine.
through it.
No.
I'm trying to piece together.
I think you're thinking about when we assay factors like factor VIII and factor IX,
Okay.
and talking about non-parallelism, I think. So that's where we do multiple different dilutions of the patient's plasma to measure factor VIII levels, and we have to do at least 3 dilutions so that we can plot a line of
that was it.
Yeah, of the APTT, and how the APTT is corrected or not corrected by the patient's plasma, which allows you to then derive factor VIII levels, for example. And for anyone listening at home, and if you can't remember this, there's a podcast on this, so just go back to the assays of factors in Practical Haemostasis podcast episode. But basically, it's really important that when you assay any factors that you do at least 3 dilutions so that you can plot a line, and you can then also do 3 serial dilutions of the reference plasma and plot a line. And you need to make sure that they're parallel, those 2 lines. So what I mean by that is less than a 20% deviation between the 2 lines, so they should be parallel on the graph. And that's something that the machines will automatically check and will flag up if there is this thing of non-parallelism. And as you say, non-parallelism is suggestive of there being the presence of an antibody or an inhibitor, because of the sort of differential effect of diluting the plasma and diluting the antibody within the patient's plasma. But before we even do factor assays, a mixing study, as you said, is the first initial screening test for an inhibitor. And classically in the textbook, what would you expect to see with a patient when you're doing a mixing study?
So if there's a clotting factor deficiency, it will be prolonged in theirs, and then when we add the sample that we know has a proper amount, it should correct.
Yeah, so just to recap, the mixing study is usually a 50-50 mix. That's what most labs do. And it's 50% or a ratio of 1-to-1 of normal patient plasma, so reference plasma with, as you say, normal amount of all the clotting factors in and no inhibitor. And you mix it with the patient's plasma at a 50-50 ratio. Now, if there is a factor deficiency in the patient's plasma, by adding 50% normal plasma, that will correct it will correct the APTT, because the APTT is sort of calibrated such that it will be a normal number within the normal range if there's 50% and above. So if it corrects, so it goes right back to the normal reference range, then that suggests that there is a factor deficiency. So when you do a mixing study and it corrects, then it means that you have a factor deficiency, which you are correcting by adding the reference plasma. However, if you do a 50-50 mix of the patient's plasma and the reference plasma and it fails to correct, i.e. it does not get back into the normal reference range, then that suggests that there is something inhibiting rather than it being a factor deficiency, i.e. an antibody in there. And that could be against Factor VIII, Factor IX, Factor 11, Factor 12, potentially, anything that would explain that prolonged APTT with a normal PT, for example. Okay? But remember, there was a nuance to that, and that was that we had an additional incubation step.
Yes.
So do you remember we do a mixing study and then we immediately measure the APTT, and then we do a mixing study and we incubate it, and then we incubate it for 120 minutes at 37 degrees. And then we measure the APTT. And do you remember why it's really important that we do an incubated 50-50 mix?
I remember us talking about sort of types of inhibitors, type 1 and type 2, and how one acts immediately and one's sort of delayed. If I'm completely honest, I don't remember what the sort of the kinetics part of that was.
That's
You're probably
fine.
going to have to re-enlighten me.
Yeah, no, that's fine. I think let's just really break it down, especially for everyone at home as well. So we've said inhibitors are antibodies that can be against either specific clotting factors or phospholipid. We're not talking about the lupus anticoagulant today. We can then divide our circulating inhibitors into either time-dependent or immediate acting. Okay, so time-dependent inhibitors are classically your antibody against Factor VIII. And so what I mean by that is the antibody needs some time to find the Factor VIII, bind to it, and inhibit its action, okay? And that's why we must do incubation at 37 degrees for 120 minutes. Otherwise, if we just did an immediate mix and we didn't do an incubation mix, then we will miss an inhibitor to Factor VIII, because the addition of the normal plasma will go in and it will correct the APTT, because the antibody in the patient's plasma hasn't had time to bind to Factor VIII yet, and we'll think, oh, it's a factor deficiency, great. And we might miss, therefore, the presence of a Factor VIII inhibitor. So Factor VIII inhibitors are always time dependent. They need time to bind to Factor VIII and to cause their mischief, okay? The other type of circulating inhibitor is an immediate acting inhibitor, and those are your Factor IX inhibitors. So they don't need time to bind for whatever reason. Maybe the affinity is higher, I don't really know, but the antibody will bind straight to Factor IX and inhibit its action straight away. So in an immediate mix, straight away you won't get correction of your APTT with a Factor IX inhibitor present. And it also kind of explains that immediate effect of an inhibitor, and how in Haemophilia B situations you get that immediate effect of the immediate antibody, which coincides and causes the anaphylactic reaction, okay, which is circling back to that case we talked about at the beginning. And that's why patients with Haemophilia B actually need their first 20 doses of BeneFix given in a hospital. They can't just take it home and give it at home with IV access. They need to have it in a hospital with anaphylaxis trolleys, and also usually, because they're children, if they're having prophylaxis, pediatric resus available, okay, because of the risk of anaphylaxis. So you've got your antibody that can bind to phospholipid or clotting factors. We're talking about clotting factors. The clotting factor antibodies can then be divided into time dependent, which is your Factor VIII inhibitors, and therefore need an incubated 50-50 mix, and your immediate acting Factor IX inhibitors, which don't need an incubation step. So the mixing study can actually be extremely informative, because if you have, let me work these through with you. So you've got your normal plasma, and you've got your patient's plasma, and your patient's plasma, the APTT is prolonged. We then do a incubated mix, and the APTT corrects to the normal range. We do an immediate mix, and it corrects to the normal range. What is the issue in that sample?
They have a deficiency.
Excellent. So then we would go on and assay the factor levels responsible for the APTT. I should say at the beginning, they had a prolonged APTT and a normal PT, we're assuming. Okay, another example. So this patient's also got an isolated prolonged APTT. And we add the normal plasma to the patient's plasma, and in the incubated mix, it's prolonged, and in the immediate mix, it's prolonged. What do you suspect?
So if it's immediate, we're thinking a Factor IX, so it's an immediate acting inhibitor.
Exactly.
Factor IX.
Yeah, so really informative. We already know what we might be looking for. And then if we've got a normal, and we've got, if we've got your normal patient plasma and your normal reference plasma, and your patient's prolonged APTT, we do an incubated mix, which is prolonged, and an immediate mix, which is normal. What are you suspecting in that situation?
So that's likely our Factor VIII. So
time dependent inhibitor.
Time dependent. Yeah.
Yeah. Brilliant. Great. Okay, great. So if our initial screening then does suggest an inhibitor, then we need to go on to do a Bethesda assay.
Which sounds like something out of Dungeons and Dragons.
I actually don't know where the Bethesda word comes from, and I'm probably butchering all of the pronunciation.
Yeah, I think that's standard in medicine anyway, isn't it?
But that's the next assay to talk about.
Okay.
Okay, so do you know what the purpose of a Bethesda assay is?
So, did a little bit of research before this, because I don't want to come across as completely stupid. But from what I understand, it's to quantify the level of clotting factor.
Clotting factor?
Inhibitor. Damn it! I was so close to not sounding stupid.
Sorry, David. Basically, if someone's got an inhibitor, it's really useful clinically, particularly in patients with Haemophilia A, to know how strong is that inhibitor. Because the more inhibitor and the stronger it is, the worse the bleeding and the more difficult it is to treat that patient. And so, therefore, we need a way to quantify, okay, you've got an inhibitor, but is it a really weak one or is it a really strong one? And therefore, that can influence management. So, it's a way of, basically, I think of a Bethesda assay. It's, okay, we think you've got an inhibitor. How strong is it? Okay, so it's actually it's a definition, essentially. And that took me a really long time to get my head around. And there's a graph, so I highly recommend, if you're not driving, or if you are driving, do this when you get home. But go on the Practical Haemostasis website again, because it is so good for practical haemostasis and this clotting lab stuff. And go on the Inhibitor Bethesda Assay page. There is a graph. It's a straight line graph of essentially your percentage down the y-axis and your Bethesda units per milliliter on the x-axis. And there's a straight line. And for ages, I was like, how did they get this graph? But basically, it's a mathematical expression. So 1 Bethesda unit is defined as the amount of inhibitor that will neutralize 50% of 1 unit of Factor VIII activity in normal plasma after 120 minutes incubation at 37 degrees. So we always incubate.
So it's kind of like the backwards version of a mixing study. So mixing study is like how much it takes to correct, and this one is how much inhibitor it takes to inactivate.
It's almost the reverse of a factor assay. Where you're using a factor.
A factor assay. That's what I meant. Yeah,
where you're using a factor deficient plasma in the lab, and you're using your patient's plasma and mixing it in to see how well you can correct that factor deficient plasma, and that's how you basically derive your Factor VIII level for a patient with a 1-stage clotting assay. And I know what you mean. This is almost the reverse. So it is a mixing study. that we do, and a Bethesda unit is the amount of inhibitor that when you add it to normal plasma containing a known amount of factor VIII will neutralize 50% of 1 unit of factor VIII activity in normal plasma after 120 minutes incubation at 37 degrees. So the incubation thing, just always remember incubation is generally done at 120 minutes at 37 degrees. And that's just a standard thing, but you need to quote that in your definition of a Bethesda unit, and you could well get an essay on this or something. And basically the graph, the straight line graph, is just an expression, a graphic expression of that statement. Okay. So that's the first thing to say. So don't worry about where they got the graph from. That graph is always going to be the same. It's a straight line mathematical expression of the Bethesda unit. Okay. And we will use that graph to then work out how strong a patient's inhibitor is in Bethesda units, which we now need to talk about. So how do we do a Bethesda assay? So, and there's some really nice diagrams. I really like the graphics on practical hemostasis for this. So if you are able to look at it at the same time as listening to this podcast, it's probably really helpful, David. I don't know if you've got it up in front of you.
I've got that little graphic.
You've got diagram. Yeah. Okay. So basically what we do is we take your diluted patient plasma, which we think contains the inhibitor, and we do a 1-to-1 mix with pooled normal control plasma, which is your source of known amount of factor VIII. We mix it together, incubate it for how long, David?
120 minutes at 37 degrees.
Excellent. And then we do an assay after that incubation to measure the residual amount of factor VIII, okay, which we expect will have dropped as that time-dependent factor VIII inhibitor has had time to bind to the factor VIII, inhibit its activity, and so we assay a more prolonged APTT, one-stage clotting assay, okay?
Yeah.
But then we need to compare it because we can't just say, okay, it's taken it down by this much, a bit like when we do an anti-10A assay, actually, where we add the patient's plasma as a source of anti-10A drug, like a DOAC of some kind, and we mix it with normal plasma and we see how much it's dropped by. We need to compare it to a control because factor VIII and factor V in particular will deteriorate with time. So just by the very virtue of having a pot of plasma with factor VIII and factor V in it and all the other factors, and if we just incubate it at 37 degrees for 120 minutes, your factor VIII will drop because it decays, it deteriorates, okay? And you lose activity. So if you didn't compare it to something else, then you can't actually truly derive how much the factor VIII has been brought down by an inhibitor in the patient's blood rather than just the natural decay of the factor VIII. Does that make sense?
Yeah, so you need a standardized model,
you need a control.
Yeah.
Exactly, you need a control. So in a standard classical Bethesda assay, your control is taking the same pooled normal control plasma with a known amount of factor VIII. And then instead of adding the diluted patient plasma containing the inhibitor, you do a 1-to-1 mix with just buffer to keep the pH at 7.4. Okay? And you do a 1-to-1 mix of that, incubate it for 120 minutes, 37 degrees, and measure the residual factor VIII activity in that. It's only then that you can then compare the residual factor VIII activity from those two solutions and work out the difference in factor VIII, which tells you, therefore, how much the factor VIII has dropped due to the inhibitor being present. Does that make sense?
Yeah.
Okay. So you derive your residual factor VIII activity and you express it as a percentage. So obviously, if there was no inhibitor, then it's 100% because nothing has dropped other than just the natural decay, which you've taken into account from your control. And then otherwise, if there is an inhibitor, it will have dropped to anything below 80%. So we say if you've mixed the patient's plasma with normal plasma and the factor VIII level, residual factor VIII level comes back at 80 to 100%, then we say, okay, well, by definition, there is no inhibitor. Because if there were an inhibitor, we would have expected the factor VIII to have dropped by more than that. So I guess that must be like the end margin, that 80 to 100%.
Okay.
So by definition, if your residual factor VIII activity is between 80 and 100%, then the sample does not contain an inhibitor. And you can be like, okay, great, there's no inhibitor. Let's move on and try and find out why this patient's got prolonged APTT. However, anything below that percentage suggests that there is an inhibitor present. Now, to be able to use that graph, which is the mathematical expression of a Bethesda unit, so the straight line graph that you can extrapolate off, you need to work within the range of 30 to 60%. Okay, so because the Bethesda, we said, was the amount to neutralize 50% of 1 unit of factor VIII, which is like bang in the middle of the graph, but we allow you to use that straight line graph anywhere between 30 and 60%. What this means is you need to do a set of doubling dilutions of the patient's plasma to find a dilution which will result in anything between 30 and 60% residual factor activity. Because if you, so for example, therefore, if you've got somebody with a really strong inhibitor, then when you do a 1-to-1 mix with just a, let's say, 1 in 10 standard dilution, then actually you're going to have like basically no factor VIII left, no residual factor VIII left. And you just can't accurately extrapolate off the curve when it's that far out of the 30 to 60% range. So,
and every time you do that doubling dilution, does that count as a Bethesda unit?
No, so we will get rid of the dilution at the end.
Okay.
Don't involve Bethesda units yet.
Okay. Back off.
Back off, exactly. All you need to do is do further doubling dilution. So 1 in 10, okay, that comes back as like, I don't know, 1%. I'm making this up, but like, let's say it came up at like 1% Bethesda unit. So that's not something that we can, not 1% Bethesda units, 1% factor VIII activity.
Yeah.
Okay, so then we're going to do a 1 in 20 dilution. Oh, it's a bit higher. It's come back at like, let's say 10% activity. And then we do a 1 in 40 dilution. I'm like, oh, it's now coming back at like 20%, but we still can't extrapolate off the graph yet. So let's do a 1 in 100 dilution. And 1 in 100 dilution, it comes back at, let's say, like the example on the Practical Haemostasis website, 36% residual activity. And we're like, great, it's now between the 30 and 60% window. So then we go at the y-axis, we go at 36% and we extrapolate across to the straight line of the Bethesda expression, and we go down to the x-axis and it's come back at 1.475 Bethesda units on the graph, okay?
Yeah.
Now that's Bethesda units per mil, and what we now need to do is multiply out the dilution to give us our actual Bethesda unit titer. So we did a 1 in 100 dilution to achieve 36% residual factor activity. So we multiply by 100. So we do 1.475 multiplied by 100 is 147.5 Bethesda units. So that's a strong inhibitor.
Yeah.
Yeah. And so that's how we use the graph to then give us the Bethesda unit, which is then something we can use to compare between patients or within the same patient as to the strength of the inhibitor.
Yeah. Okay.
And that's really useful because, you know, once somebody's got an inhibitor, you might want to know if that inhibitor is getting stronger with like treatment that you've given or whether it's coming down if you're doing immune tolerance induction, for example, which is a treatment that you can use to try and get the patient's inhibitor to go away by tolerizing them, which we'll talk about when we talk about Haemophilia A. But what I'm trying to say is it's clinically useful and relevant to know how strong a patient's inhibitor is. Do you have any questions about that, David?
So while you were talking, I fired up the practical hemostasis graph, and it makes sense when you can see the graph. Just for listeners who are going, I can't quite brain this. But if you load the graph up from practical hemostasis and look at the little table above it, it does make sense when it's plotted like that. Yeah.
So I'll just summarize it in 4 key steps then. So you mix the patient's plasma with normal plasma and measure the remaining factor VIII activity. That's step 1. Then and then obviously compare it to your control sample and therefore derive the residual factor VIII. Yeah. Then step 2 is you do this at different dilutions of the patient's plasma until you find a dilution of the patient's plasma which neutralizes between 30 and 60% of the normal plasma factor VIII. Step 3, you use this residual percentage factor VIII to extrapolate the Bethesda units per mil from the graph. And then step 4, you can convert the Bethesda units per mil into Bethesda units titer by multiplying out the dilution.
Grand.
Yeah?
That makes sense.
Okay, cool. So that's a Bethesda assay. So it's really a glorified mixing study, as is in a way the as you say the factor assays, but that's kind of in reverse. And also it's quite similar to the anti-10A assay that we've talked about, where instead
Yeah.
of being an inhibitor in the patient's plasma, it's usually a drug that you're looking for. Okay. So then we think, oh great, we've got our head around that really complicated lab stuff, and we're good now. And then we scroll further down and we think, oh no, what's the Nijmegen modification of the Bethesda assay? Which, by the way, I might be completely butchering how you pronounce it, but it's spelled Nijmegen. Nijmen? Nijmen? I don't know. I call it the
I'll leave that
Nijmegen.
to
That's
you.
probably not right. And you think, oh no, now I've got to get my head around more complicated stuff. But it's not as hard as it might appear. And like the whole new set of diagrams on practical hemostasis makes you think you've got to learn a whole new thing. But it's actually basically the same as the Bethesda, the classical Bethesda assay. Do you know what the Nijmegen modification is?
Oh, no idea. I've literally just scrolled down and been no.
Yeah, you scrolled down and thought, oh no, like I did when I was studying this
Yeah.
first time. Basically, the reason for the Nijmegen modification of the Bethesda assay is that it avoids false positives, okay? Because factor VIII and factor V, they are particularly vulnerable to decay and deterioration with time, with that incubation step. And in particular, they're sensitive to both changes in the pH and changes in the protein concentration around them, okay? So what the Nijmegen modification does is it just says, okay, let's try and control for that better, okay? So if we look at the diagram of the classical Bethesda assay again, the diluted patient plasma is mixed with the pooled normal control plasma, which is not buffered, so the pH might be all over the place, and there's more protein in that than there is in the control sample, because the normal control plasma contains protein, as in the control you're using just buffer in the classical one, yeah? And when you're doing your dilutions of your patient's plasma, you're also using buffer rather than anything else, which again is going to affect the protein concentration and therefore may differentially affect the factor VIII deterioration. And if you have more factor VIII deterioration because of differences in pH and differences in the protein concentration, then it could make it look like there's an inhibitor when actually there's not. It's just you've got more factor VIII decay in the patient sample than in the control because of differences in pH and protein concentration.
That'll be a really low level titer.
It would, yeah,
for the
it would.
inhibitor.
It would, yeah, it would. But it could still give you a false positive, which would make you think, oh, okay, it's an inhibitor, right?
Yeah. Yeah.
So what the Nijmegen modification does is it's the same process, okay? So you don't need to get your head around any different process, but instead of using just buffer in the control sample 1-to-1 mix, you use a factor VIII deficient plasma, so the protein concentration is very similar to that of the patient's plasma. Yeah?
Okay.
Following?
Yeah.
And also when you do your dilutions, you're using factor VIII deficient plasma rather than buffer.
Okay.
And the control plasma this time is also buffered. So you're basically buffering the pH and you're trying to keep the protein concentration similar by using factor VIII deficient plasma rather than just buffer.
Yeah.
And so it basically that's the Nijmegen modification. It's nothing more than that. And most labs you'll find will do a Nijmegen modification of the Bethesda assay. Our lab do a Nijmegen modification.
And is that as a default? You don't have to request that. Okay.
No, I don't think so. But I mean, check with your own lab. But the reason why it's useful to know is I think you just have to state it. It's a Nijmegen Bethesda units rather than just Bethesda units.
Okay. That feels very exam specific as well.
Yeah.
You can see someone getting quite finicky about they didn't say this, do they appreciate? Yeah.
Exactly. So but it's no more complicated than that. It's just about controlling for pH and protein concentration. To try and reduce the variability between labs, I guess, as well. And then the other thing that you can do, which less labs do, I think, is heat treatment. And the heat treatment makes it more sensitive, the Bethesda assay. So with heat treatment, what you do is, well, basically the argument for heat treating your Bethesda assay is that the other variable in the assay is the amount of factor VIII that the patient has in their sample. Because obviously you're using the patient sample as a source of inhibitor, but we know that factor VIII is an acute phase response. So in pregnancy, in infection and stuff, you may have a much higher factor VIII level in that patient's blood than you normally would have or with another patient. So, and then if you've got a very high factor VIII level in the patient's blood, you may miss a very weak inhibitor because you've got so much factor VIII that's sort of mopping up some of that inhibitor. So what you can do is take the patient's plasma sample and heat it up to 58 degrees for 90 minutes. And what that will do is just inactivate all of the patient's factor in the patient's blood. But the antibodies are resistant to that heat treatment. And it just allows you to make that patient's plasma sample contain just inhibitor and not factor levels that may influence the result of the test. But again, this is like, a lot of people argue that's kind of a pointless step that's probably not necessary, because if the inhibitor was so weak that the amount of factor VIII the patient has mops it up, then is it even clinically?
Yeah.
But yeah,
that's just that nice to know, not
Yeah.
clinically interesting. Yeah.
But just remember with the heat treatment that the reason why that works is because you're able to inhibit factor, but not the antibody, because the antibody is temperature resistant.
Yeah.
Okay, great. So that's how you then detect an inhibitor and quantify it in a nutshell in terms of the lab. Can you think of any other ways one might approach detecting an inhibitor other than these functional assays that we've done?
Not really. I guess. I guess just the process of elimination, but not really. I got nothing useful.
So you could do an ELISA because it's an antibody.
Okay.
So you could have a well.
If you know, kind of got an idea what you're aiming for. I guess if it was immediate or or if it was delayed, you've kind of got an idea of which antibody you're looking for then, I suppose.
Right, I see what you mean. Yeah. So if you suspect factor VIII, you could go on and do an ELISA for because each ELISA plate would have to be specific for the factor that the antibody is against. Yeah. And so you can do a factor VIII inhibitor detection by ELISA, whereby the microtiter plate contains recombinant factor VIII, which is immobilized. Then obviously you add your diluted patient serum or plasma to the wells, incubate it, and then do a washing phase, and then add an anti-human IgG, and then add a color that changes color or whatever, and you can then detect it. Pros and cons of doing an ELISA over a Bethesda assay?
I guess unless you're doing every single antibody, you're looking for every one of the clotting factors. The clotting factor inhibitors. You've got to go broad, haven't you, to find what you're looking for, as opposed to being slightly specific.
I don't know if that would be difference, but I guess what you're getting at is that it might detect non-neutralizing antibodies, because there may be antibodies that bind to factor VIII but don't actually influence its activity, depending on where they bind the factor VIII. And so
I wasn't smart enough to go there. But
okay, well, I was giving you the benefit of the doubt there.
Yeah, I should have shut up.
Just take it, David.
Yeah. That's exactly what I meant. Thank you,
exactly. There you go. Better. Yeah. Basically, ELISA's the problem with a non-functional study, and I think we talked about it with fibrinogen assays as well, where you can do an ELISA for fibrinogen instead of doing the Klaus fibrinogen assay, is that you can detect. In this case, you can detect an antibody which may not necessarily be clinically relevant if it's not affecting the activity of the factor VIII. But sometimes it can be clinically relevant because some antibodies might not affect the activity of factor VIII, but they're affecting the clearance of it. For example, they mark the factor VIII for then, opsonization and removal. And so I guess
ubiquitin.
Yeah. So I guess it might be useful in somebody where you think there's something going on because you give them their recombinant factor VIII, and then when you measure the peak at 15 minutes it's high, and then at 4 hours it's way lower than you would expect, so the half-life appears a lot less for that patient. That's when an ELISA for a sort of non-neutralizing antibody might be useful to detect that, because you would miss that type of antibody on a Bethesda assay because it's not affecting the factor VIII activity, it's just increasing its clearance of it.
Yeah.
So that's probably the benefit of an ELISA, but generally we don't do those. Generally, it's the Bethesda assay that we do, because most of the time the antibody will affect the activity of the factor VIII. I mean, that's why we clinically picked it up in the first place. Yeah?
Yeah.
Cool. Okay, so that's all the lab stuff. So we do a mixing study, both incubated and immediate. That gives us a clue as to whether it might be a factor VIII or a factor IX antibody,
Yeah.
because of them being time dependent and time independent. And then we go on to do a Bethesda assay to basically confirm that the inhibitor is present and quantify its strength. And then we also can consider doing an ELISA if we weren't happy with the Bethesda assay for whatever reason. We should probably also just touch on the fact that, I guess, where do you think these antibodies have come from? Do you think they are allo antibodies or auto antibodies?
So I suppose in somebody who's having recombinant therapy, your body is making them, aren't they? Against. So I think it'd be an allo antibody if someone was getting it from someone else.
Yep.
And if suddenly it comes from nowhere, like an acquired haemophilia would be an auto antibody.
Yeah, good.
So I'm getting my brain around that.
No, that's okay.
Yeah.
That's okay.
Yeah.
So yeah, exactly. So all these patients we've been talking about with haemophilia, especially in your severe haemophilia, where these patients don't make any factor themselves, or they make very little, essentially their immune system hasn't been tolerized to the presence of this molecule floating around, this factor VIII. And then when you give recombinant factor VIII, particularly around times of lots of inflammation anyway, like around surgery and emergency doses with infection, whatever, then your risk of developing an antibody against factor VIII is pretty high. And we'll talk about risk factors for inhibitors and all of that when we talk about haemophilia A, like more in a clinical podcast. But so allo antibodies are what we're talking about most of the time. But as you correctly identified, you can also have this condition called acquired haemophilia A, which is a sporadic autoimmune disease where the antibody is an autoantibody. And it's useful we talked about how you can have both time dependent and time independent immediate acting inhibitors. And we said that all the factor VIII inhibitors tend to be time dependent for whatever reason. And you can also talk about the kinetics of a time-dependent inhibitor antibody. And I think that's what you were talking about when you referred to type 1 and type 2, like much earlier on in our chat. And do you know anything more about the difference?
So from what I understand, a type 1 is linear inhibition. So it's affected by both time and concentration, while type 2 is a bit more complicated.
Yeah, exactly. Yeah. And again, there's a graph on the Practical Haemostasis website which basically shows residual factor VIII activity against incubation time. And you've got a straight line for your type 1 factor VIII inhibitor, which is your time dependent, like with time and concentration, you get a reliable change in the inhibitor activity. Which is why you need to incubate your mixes and your Bethesda assay for the 120 minutes to allow it time to have maximal effect so that you can detect it. And your more complex or type 2 kinetics is not linear, it's a curved graph. And the reason why I bring that up with the allo antibody chat is that generally your allo antibodies, so patients with haemophilia A and B where they develop an allo antibody against recombinant therapy, they tend to be first order kinetics with a nice straight linear graph, which means that with more time, the inhibitor has like more and more of an effect.
Yeah.
And so that sort of creates complete inhibition of factor VIII activity, because give it enough time and enough concentration, it will inhibit all of the factor VIII. As with autoantibodies, they tend to follow the sort of second order type 2 kinetics where it's not linear, and therefore you can see on the graph on practical hemostasis, it goes down initially quite steeply and then it kind of curves off and flattens. And so even giving it, 120 minutes, that antibody may not inhibit all of the factor VIII that's present, which is what gives it clinically a much more variable picture. So it's not like just they bleed. It can be quite variable in terms of how they bleed. And actually the Bethesda assay strength the Bethesda units of a auto antibody, like an acquired haemophilia A, is much less useful because it's actually much less predictive of how severe the bleeding might be.
Yeah. Okay.
And that's because of the first and second order kinetics, respectively, with the time-dependent factor VIII inhibitors.
Yeah.
Okay, great. Shall we go back to the cases that we discussed at the beginning?
Yeah.
So we talked about the first patient that was a patient with Haemophilia B. And he
Yeah.
had his third dose of BeneFix and he developed anaphylaxis. So what do you think might have happened in this situation, David?
So we thought maybe this was an Allo antibody
Yeah.
that he's produced against benefits. He's then got, he's been primed a couple times.
Yeah.
It's come in, massive immune response.
Yeah, exactly. And what investigations would you do to prove that? I mean, obviously, treat the anaphylaxis.
Yeah. Adrenaline first.
Yeah.
So we could do a mixing study.
Okay, good. What would you expect to see?
I'd expect this to be prolonged, their sample, and I expect the incubated mix and the immediate mix to be both prolonged.
Excellent. And then what would you go on to do?
So then I could do my Bethesda study to see to quantify my problem.
Yeah, excellent. Okay, that's really good. Brilliant. So then the next case was a patient with severe haemophilia A, who comes in with a joint bleed that was getting worse despite their emergency dose. And so again, what do you think is happening here?
So yeah, this sounds slightly different, doesn't it? It sounds like there's, it's not an immediate type response going on there, and it's sort of continuing on in the background. Probably the longer time you give him, the worse it's sort of getting. So I suppose in this, because they're not responding as well, it sounds like we need to do a mixing study again, give it some time to incubate.
Okay.
Potentially it shows after that period of time that we are immediately it's normal.
Okay.
It returns to normal, and then in our incubated long periods, it's hopefully prolonged for the sake of this clinical study.
Yeah.
Then we can do our Bethesda study.
Yeah.
And hopefully that will give us a titer.
Yeah.
Or a unit, and then it's management, which we haven't really talked about much.
No, we haven't, and I don't want to get too much into it, but
no. Yeah.
Essentially, you have to use bypassing agents. So you have to accept that antibody. Most of the time, you have to accept that antibody, particularly if it's quite high, is going to inhibit factor VIII. And there's no point giving more recombinant factor VIII because you're just going to stimulate further antibodies to be made. So sometimes what you can do is you can give Nova 7, so you can kind of boost the clotting system by kind of ultra stimulating thrombin production through more extrinsic pathway activity. Another thing you can do is something called FIBA, which is an acronym for Factor VIII Inhibitor Bypassing Agent, which is essentially activated prothrombin complex. So obviously PCC is your 2, 7, 9, and 10 because it was developed by drug companies to reverse warfarin essentially. But in this situation, it's activated PCC. So the factor VII is active and ready to go. So it's very procoagulant, but you can use that to, again, sort of boost the clotting to try and get around the problem of having an inhibitor. And then longer term, we've got this amazing drug called emicizumab, which is a monoclonal antibody, which basically mimics the effect of factor VIII, and by cross-linking 9 and 10 to allow the 10A's complex to form and to allow clotting to go ahead. And that's been a bit of a breakthrough for patients with an inhibitor, like long-term for prophylaxis. So that's something that you can do as well.
Do you see a time in which we use the emicizumab instead of recombinant factor VIII? Or
It is already being used. So emicizumab's licensed for severe haemophilia A with an inhibitor initially, but then it got further approval for any patient with severe haemophilia A, even without an inhibitor, as prophylaxis. There was a push to get it approved for moderate and mild haemophilia patients, but that was rejected by NICE, I think, for cost-effective reasons. And also because your mild haemophilia patient wouldn't normally have prophylaxis. And just to say, I used to think that emicizumab was like a cure and completely replaced Factor VIII activity, but it doesn't. It just renders the patient with a mild Haemophilia A phenotype. So they can still get breakthrough bleeding. And then actually that can be a bit tricky to manage.
Yeah, there's
Because,
nowhere to go.
yeah, well, there are things. You can still use Fever and Nova 7, for
Okay,
example.
in the acute phase. Yeah.
Yeah, and sometimes you can use porcine products as well, if
Okay.
the antibody isn't shown to react to porcine factor VIII. So that's where you would do a Bethesda assay, but using porcine factor VIII in the. So when you take your sample of control plasma with the known
Yeah.
factor VIII, you have pig factor VIII in there, and you see whether that brings the pig factor VIII level down. So it's a Bethesda assay with porcine product, because that's really useful to know if someone does have an inhibitor, because then you could use this product called Obazor, which is pig derived, and that can be used for breakthrough bleeding for patients with an inhibitor. And the beauty of that is you can measure the amount of factor VIII you're giving and actually titrate it, rather than this Fever and Nova 7 where you just basically chuck a whole clotting stuff into the patient. You can't really
We need
measure
to
anything.
fix this now.
Yeah, exactly. And especially for like going to theatre and stuff, it's quite reassuring to be able to measure a level and go, okay, that's at 100, like I'm happy. Anyway, we will chat about all this great stuff.
I derailed you. I derailed you.
No, it's fine. I could chat about it all day. I love it. I love it so much. Okay, right. I thought maybe also I had this case from my on-call last week, and I thought it might be a good one for us to very briefly just chat through, just to bring all our concepts together that we've kind of covered in all of our podcasts so far. If I'm not boring you too much, David, do you have time for this?
Yeah, let's go for it.
Okay, great. So that was the right answer.
Thanks, boss.
So I had a case last week where I was phoned about a young girl who had a fall and had hit her head and had a big subdural bleed, a chronic subdural bleed, which needed burr hole evacuation, neurosurgery basically. And for whatever reason, the neurosurgeons did a clotting screen without a bleeding history. So obviously that was the first thing I fed back to the neurosurgeons.
I bet they took that well.
They did actually. They were like, oh yeah, sorry about that. This has created a lot of trouble, probably for nothing. But they basically did a PT and an APTT. PT was normal, APTT came back prolonged. And so then they phoned us to say, can we take this patient to theatre? So what sort of things you're the heme reg now, David. Take it away.
So I guess we need that clinical history, don't we?
Yeah.
Is there any history of bleeding problems?
So
from
initially
wherever?
They said no, because I said, why did you do the clotting screen? Is there a concern? And they said no. But this is a female. Is there anything you'd ask them to go back and check?
I almost said something inappropriate there, but menorrhagia. I would like to know whether bleeding's a problem.
Yeah, exactly. Yeah. So menorrhagia in particular for a young girl. And actually, when they did go back and specifically ask her that, oh yeah, actually she has had really heavy periods with flooding and clots, using like 5 tampons a day, got iron deficient, and she ended up being on the oral contraceptive pill, which she's now been on for the last few years to control her bleeding. And there was a family history of her mum like having lots of fainting episodes while she was on her period as well. And she's not had a baby before or anything like that would be useful. Okay, cool. Then what would you do?
So we've got a prolonged APTT, so I do a mixing study.
Okay, good. So the lab do a standard 50-50 mix, both incubated and immediate. And they actually both normalized on a 50-50 mix. What does that make you think of?
So that makes me think there's a clotting factor deficiency.
Okay, yeah. So then what are you going to go on and do?
So I would do my individual factor assays.
Which factors would you assay?
8.
Yep.
9.
Yep.
11.
Yep. Very good. You could do 12 for academic interest.
Yeah.
But obviously that doesn't confer a bleeding risk, so you don't need to. So good. So I trot down to the lab with a spiced bun for the lab staff to say, here's a nice bun.
The important currency of lab members. Yeah.
Please, could you fire up the factor assay machine? And they agree with the receipt of the iced bun.
Good to know. That's what I'll take away from today. Yeah.
No, honestly, do keep your biomedical scientists on side, because they are all part of the team.
Keep them fed.
Yeah, keep them fed, keep them happy. So they do the factor assays and they come back as normal. They come upstairs with a printout. So, just to say, the lab need a fresh sample, so it needs to be within 4 hours, really, for it to be nice and
Okay.
reliable. Because otherwise, your antibody can get mopped up with like phospholipid, for example, if it's a underlying
Yeah.
lupus. So spoke to the clinical team. They actually very quickly got these 3 bottles down to the lab, blue tops. And so he comes up with this printout, and all the factors are like 100. So anything you'd want to check on that printout?
Thinking. No, I don't know. They're not on anything else, are they?
No, but that's a good point.
Okay.
Yeah, always think about that. We should have said that at the beginning. That's a very good point.
So my factors are normal. So clearly there's something else going on, isn't there?
Yes, but just check that there's not any
Oh yeah.
non-parallelism. Okay, you got
Yeah.
that you trust those samples.
Yeah.
Good. Okay. Great. And so, as you say, the factor assays are okay. So they're saying, okay, great. Can we take her to theatre?
So I guess we
Can we
haven't
take her to
mentioned
theatre?
it.
We've just had a tonic-clonic seizure. Now we're taking her to the CT scanner. Can we take her to theatre, please? Are you happy?
Let me quickly chat to my consultant.
Yeah, that's good.
So just thinking out loud, like, this sounds like a lupus anticoagulant in somebody
Okay.
who's banged their head.
Okay.
There's clearly going to be a traumatic kind of stimulus there, isn't there?
Yeah.
If I'm honest, I'm a bit stuck here because
Okay.
I'm not a heme So, but maybe I'll bounce it back to you. Can I go to theatre? And Harris, please.
Okay, so well bounced back to me, David. I mean, I bring it up as a case because it's not really following a textbook in that when we did the mixing study and it corrected, you're right to think about factor deficiencies, and that's totally everything you've done so far is completely what I did. But remember that a 50-50 mix can it can flood a weak inhibitor. So you could go on to ask the lab to do a 4-to-1 mix. So 4 parts patient plasma, 1 part normal plasma. But as you say, like I actually suspect this is probably a lupus anticoagulant. Probably the menorrhagia is a red herring and not explained. We've measured the important factors that would need to be at a decent level to do the operation, and they're the ones that would explain a prolonged APTT on its own. So I'm happy for the patient to go to theatre because we know that the important factors are present and at the right level, and I suspect a weak lupus anticoagulant, which is why when you did a 50-50 mix, the dump of like 50% normal plasma just mopped it all up. And actually, when I looked back, they'd done an APTT every day and it was going down since her head trauma. And exactly as you say, a lupus anticoagulant is antibody against phospholipid. And when you have a big knock to your brain, a bit like when you have a stroke, and you can often get an acute phase reactant of an antibody against phospholipid from all the phospholipid in your brain. Because remember, we used mashed rabbit brains, didn't we, in our thromboplastin? So lots of phospholipid in the brain, a bit of a knock, bit of phospholipid goes into the blood. You make a lupus anticoagulant, which is probably going to be transient and already looks like it's coming down. So my advice was go to theatre. Obviously, I did discuss this with a consultant, so that's also you've done a really good job of working through that case and then seeking help at the appropriate time. And I think any consultant you work with, especially as an ST3 reg, would be quite impressed with what you've done. So obviously something's working.
Yeah. I'll be like, oh, I've been listening to the Basics to Brilliance podcast, so
Exactly. Plug.
Yeah.
And so basically, then what I advised is that the GP, they asked the GP very kindly to do another APTT in like 12 weeks time, because that's why when we talk about antiphospholipid syndrome, that's why you have to have 2 tests that are positive at least 12 weeks apart, because especially a lot of people are testing for antiphospholipid syndrome in the context of an acute stroke where you get a bit of phospholipid release presumably and you get an acute phase antibody to the phospholipid. And I think at that point, if it is still prolonged in 12 weeks time, then probably we should then do a lupus anticoagulant screen, just so that this poor girl doesn't have this prolonged APTT kind of over her head for future operations and future procedures. So yeah. quite a good
Lovely.
case. Yeah, I thought that was
Wraps up a lot of things as well.
yeah,
doesn't
and
it?
you managed that really well. So I'm really pleased. Well done.
the Padawan is getting there slowly.
Shall we summarize them?
Yes, please do.
Okay, so inhibitors in the context of haemostasis are antibodies, and in this situation they are against, we've only talked about antibodies against specific clotting factors and not phospholipids like lupus anticoagulants. We can have inhibitors that are both time dependent, like Factor VIII inhibitors, which can exhibit either first or second order kinetics. Typically, an allo antibody will exhibit first order kinetics, and an auto antibody will exhibit second order kinetics, so less predictable. And then you've got your time independent or your immediate acting inhibitors, which are classically against Factor IX and can mediate anaphylaxis against recombinant Factor IX. The second point is in terms of lab testing, the mixing study is really important for screening for an inhibitor, but remember that you can flood a weak inhibitor with a 50-50 mix, as per the case we've just discussed. And remember to always do both an immediate mix and a mix of incubation, which is for how long, David?
An hour and 20 minutes, 37 degrees.
120 minutes.
What did I say? An hour and 20.
Yeah.
Sorry, 2 hours or 120
minutes. Baby brain.
Goodness me.
So remember to always do that incubated mix, otherwise you will miss a Factor VIII inhibitor. And then go on to do a Bethesda assay, which is essentially a glorified mixing study using the patient's plasma containing the inhibitor to neutralize or bring down the known Factor VIII concentration. And then you've got your Nijmegen modification and your heat inactivation. And then I guess the third thing to say is always think about an inhibitor in somebody who has non-parallelism when you're doing your factor assays, or has a prolonged clotting test which fails to correct on mixing, or a clinical history where somebody's either getting more bleeding than you would expect, or a change in the pattern of their bleeding, or their treatment isn't working in the way that you would expect it to. And I would say that's a good place to stop.
Deal.
Great. Okay. Well, thanks everybody for listening. And we do
pleasure as always.
Leaving us a review. We are now CPD approved, accredited with the Royal College of Pathologists. So if you have listened to our podcast, don't forget to put that on your e-portfolio. It's 1 CPD point for every podcast you listen to. So now your commute can be more interesting and you are doing your e-portfolio at the same time, which is a double win, right?
You're welcome.
We'll see you next time.
Yeah, look forward to it.
Great. Okay, see you later. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.